Imagine having a skin condition that is um, completely non-contagious. I mean, fundamentally uninfectious. But it practically guarantees you are going to contract relentless chronic infections.
Yeah, it's a total paradox.
Right. Today, we're looking at a medical mystery that turns the body's most resilient barrier, your skin, into this open door for bacterial and fungal invaders. Welcome to today's deep dive.
We have a lot of ground to cover today.
We really do.
Yeah.
We've gathered this massive stack of clinical guidelines, BSHH reports, research papers, and patient leaflets. And we are looking at a condition that completely flips our understanding of skin on its head.
It really does.
Our mission for you today is to unpack a very specific, honestly very dangerous mystery surrounding a condition called lichen sclerosus, or LS. Okay, let's unpack this. How does something that is not an infection literally invite secondary infections in?
What's fascinating here is that we have to look at lichen sclerosus not just as a superficial skin issue, because it's not. It's this complex, cascading failure of the body's architecture.
Like a structural collapse.
Exactly. It's a vicious interplay of autoimmune misfires, structural collapse, and then opportunistic infections. And the medical literature we're looking at is dense.
Yeah, lots of jargon in these papers.
Oh, for sure. We're going to be talking about things like, Th1 inflammatory profiles, cytokines, and extracellular matrix proteins. But don't worry, we are going to decode exactly how our own immune system can inadvertently sabotage the very walls meant to protect us.
And why understanding that mechanism is, well, it's the only way to actually find relief if you're dealing with this.
Precisely.
So to understand how those secondary infections get in, we first have to understand how the wall is crumbling from the inside out, right? Let's look at the etiology of LS.
The root cause.
Right. And the exact root cause is still technically a mystery in the medical community, from what I read. But the sources are really clear that it is an autoimmune inflammatory dermatosis.
Yeah, the immune system is essentially launching a civil war.
A civil war. Wow. So how does that start?
Well, the literature describes the inflammation in lichen sclerosus as a Th1 dominant inflammatory profile.
Okay, break that down for us. What is Th1?
So T cells, which are usually our defensive soldiers, they infiltrate the skin. And once they arrive, they release these powerful chemical messengers called cytokines.
Right, like interleukin-4 and transforming growth factor beta, which were mentioned a lot in the papers.
Exactly. You can think of cytokines as like foremen on a construction site.
Okay.
Usually they direct the healing process, they tell the workers what to do, but in LS, these specific cytokines go completely rogue.
So they're giving the wrong orders.
Yes. They instruct the fibroblasts, those are the cells responsible for building the skin structure, to stop producing healthy elastic collagen.
Oh, wow.
And instead, they tell them to lay down this stiff, scarred, fibrotic tissue.
So if our skin is a brick wall, collagen and elastin are the mortar. But here, the body's own immune system is attacking the mortar.
That's a great way to look at it. The mortar gets replaced with something rigid and dysfunctional.
But wait, I have to push back here. If this is a systemic immune issue circulating in the blood, why does it target the skin specifically? And usually, as the sources point out, the genital skin. That seems, I don't know, highly targeted for a general immune misfire.
It's a great question, and it's one researchers have grappled with. The prevailing hypothesis, which is detailed in our sources, involves elevated autoantibodies targeting a very specific protein.
Right, the extracellular matrix protein 1.
ECM1, exactly. This protein acts like the foundational cement in the basement membrane zone. That's the deep layer of the dermis.
So it's way down in the foundation.
Deep down, when the immune system attacks ECM1, that deep foundation is destroyed. Widespread hyaline material deposits in the dermis, which is basically this stiff, suffocating substance.
And that ruins the normal tissue architecture.
It completely ruins it.
Which leads to what the biopsies show under a microscope. I was reading that the epidermis, the top layer, it actually thins out, and the sources note that we lose something called re-ridges.
Yeah, the loss of ridges is a hallmark sign.
What are they exactly?
So if you look at the junction between the top layer of skin and the bottom layer, it shouldn't be flat.
Okay.
It should look like the corrugated edge of a piece of cardboard.
Oh, like those little zigzags?
Exactly. With downward-pointing pegs interlocking with upward-pointing tissue. Those are the ridges.
Ah.
They anchor the layers together so the skin can handle friction without just shearing apart.
That makes total sense.
But when the immune system destroys that ECM1 cement we talked about, those corrugated anchoring pegs are completely lost.
They just dissolve.
Pretty much. The junction flattens out and becomes incredibly weak.
The patient leaflets describe the clinical result of this, and the visual is wild. They say the skin starts to look and feel like cigarette paper.
That is the exact term dermatologists use.
It becomes white, dry, wrinkled, and it just loses all of its stretch.
Because the architectural scaffolding has been dismantled from the inside, the deep cement is gone, the anchoring pegs are gone, and the outer wall is, as you said, paper thin.
Okay, so if that Reed Ridge anchoring system is gone, just moving around in daily life, like walking, wearing jeans, going to the bathroom, must cause that paper-thin top layer to just shear right off.
It does.
The skin can't possibly hold together under normal friction.
The physical reality for patients is profound. Because the skin cannot tolerate shear forces anymore, patients experience erosions.
Like open sores.
Yeah, and purpura, which are blood spots, and severe bruising called ecchymosis.
Oh, wow.
But most crucially for our discussion, the sources emphasize fissures.
Right, the micro-fissures.
Exactly. These are microscopic, or sometimes macroscopic, tears and cracks. The skin literally breaks open under the stress of basic movement.
I was reading the clinical guidelines, and they highlight this really cruel quirk of dermatology here called the Koebner phenomenon.
Yes, the Koebner phenomenon is fascinating and terrible.
So what does this all mean for daily life? Because from what I read, it sounds like an absolute nightmare.
Well, the Koebner phenomenon means that physical injury to the skin actually acts like a homing beacon for the autoimmune disease.
Wait, really?
Yeah. When that fragile skin tears, the mechanical trauma releases alarm signals, and those signals call even more rogue T cells to the area.
So he brings more attackers.
Exactly, causing more inflammation, more ECM1 destruction, and more thinning.
So scratching an itch, which the sources say is one of the most agonizing, relentless symptoms of LS, actually creates new disease lesions right where you scratched.
Your own instinct for relief is weaponized against you.
That is brutal.
It is. And environmental triggers amplify this immensely. Friction from tight clothing, underwear seams, or vigorous sexual activity causes these microfissures.
Just normal life stuff.
Right. And then you add chronic exposure to moisture, specifically urine, which acts as a severe chemical irritant.
I saw that in the BAHHH reports.
Yeah, for uncircumcised men where urine can become trapped under the foreskin, or in individuals who wear incontinence pads, that trapped urine chemically breaks down the already compromised barrier.
Which widens those microscopic cracks.
Exactly, and that triggers the Koebner phenomenon all over again.
Okay, so we've reached the core mystery from our stack of sources. The barrier is breached. We have these microfissures. Here's where it gets really interesting, because this loops back to the paradox we started with.
Right.
The patient leaflets are adamant about this. Lichen sclerosus is absolutely not contagious. It is not a sexually transmitted infection. You cannot catch it from a towel or a toilet seat.
Correct.
It is not an infection, period.
Yeah.
Yet having it dramatically increases your risk of catching an infection.
Because by tearing the skin, you have completely bypassed the body's primary immune defense.
The skin barrier itself.
Right. The acid mantle and the tough outer stratum corneum. The gates to the fortress are just wide open.
So what gets in?
Opportunistic organisms that normally live harmlessly on the surface of the skin or in the environment, they suddenly find this warm, moist, unprotected microfissure that leads straight down into the vascular dermis.
And they just set up camp.
They colonize it immediately.
The clinical data specifically calls out fungal overgrowths, like Candida albicans, which causes yeast infections.
Yes.
And it calls out bacterial invaders, like Staphylococcus aureus, and even viral reactivations, like herpes simplex.
And once bacteria or fungi enter those cracks, they multiply rapidly. The body detects the invading yeast or staph and does what it is supposed to do, right?
Which is?
It launches an aggressive, localized inflammatory response to fight off the infection.
But wait, the skin is already drowning in autoimmune inflammation. The Th1 response we talked about is already destroying the tissue.
Exactly. The chemical signals overlap and they compound each other. The new infection-driven inflammation whips the underlying autoimmune response into a higher frenzy.
Oh, I see.
More T cells arrive to fight the bacteria, but while they're there, they end up destroying more ECM1 protein,
Which thins the skin further,
tearing more microfissures.
which invites even more bacteria inside.
It's a completely self-sustaining trap.
Think about it for a second. If you are listening to this and you've been treating what you assume is just a stubborn recurring yeast infection or maybe bacterial vaginosis, You buy the over-the-counter antifungal creams.
Right, you think it's a standard infection.
Exactly. It maybe gets a little better for a few days, but it always comes back. And the skin is just getting sorer and sorer. Going back to our building analogy, treating just the yeast when you have underlying LS fissures isn't just putting a bucket under a leaky roof without fixing the hole.
It's trying to mop up a puddle while the entire foundation of the house is actively being dissolved by the mortar.
Wow. Yeah.
Because you are temporarily suppressing the opportunistic invader with the cream, right? But the structural breach in the basement membrane remains wide open.
Because you didn't treat the LS.
Exactly.
Yeah.
And because the microbes keep getting back in, the localized inflammation never subsides.
And because these secondary infections are so loud, so painful and so visible, they completely mask the silent structural collapse underneath.
That's the real danger.
That seems to be why doctors keep missing the real culprit. Misdiagnosis is mentioned across all the medical journals we looked at.
Clinicians frequently confuse LS with simple thrush in women, or balanitis, which is a yeast infection of the glands in men.
They just see this secondary infection.
Right. The doctor sees the inflammation and the candida under a microscope, prescribes an antifungal, and sends the patient home. The root autoimmune cause goes completely unaddressed.
And the sources note that lichen sclerosus has a bimodal age distribution, meaning it primarily affects postmenopausal women, but the other major peak is in prepubertal girls.
Yes, and the misdiagnosis there can take an incredibly dark turn.
It's awful. Let's talk about that.
Because LS causes extreme fragility, severe bruising, and fissures in the genital area, it tragically mimics the physical signs of sexual abuse.
That is just heartbreaking.
It is. Clinicians have to be highly trained to recognize the specific figure-of-8 white plaque formation around the vulva and anus that characterizes LS. They have to know what they're looking for in order to differentiate it from abuse trauma.
A distinction that literally alters lives.
Absolutely.
So if we know misdiagnosis is rampant, and we know there is no permanent cure for the underlying autoimmune condition, how do you actually stop the immune system from destroying the skin and keep these infections out?
You have to forcibly shut down the local immune response and give the barrier time to rebuild. The clinical guidelines, like the BSH report, establish a clear gold standard for this. It's a course of ultra-potent topical corticosteroids. The most common one cited is cloatisol propionate, 0.05%.
But wait, ultra-potent steroids. We're universally told not to use strong steroids on thin, sensitive skin because steroids themselves are known to cause skin thinning over time.
Right.
Applying that to skin that is already as thin as cigarette paper sounds completely counterintuitive.
I know, and that hesitation is incredibly common, even among general practitioners, which unfortunately leads to underprescribing.
So why is it safe here?
You have to look at how steroids function at a cellular level. When applied, the steroid enters the cells and binds to glucocorticoid receptors.
Okay, receptor binding.
And this effectively turns off the genes that are producing those inflammatory cytokines we talked about earlier.
The foreman giving the bad orders.
Exactly. You turn them off.
Yeah.
The mechanism of the LS disease itself is causing far more aggressive destructive thinning than the steroid ever could.
Oh, I see.
You need the ultra-potent steroid to forcibly shut down that rogue Th1 cytokine storm.
So by suppressing the local T cells, the civil war halts.
Yes.
The fibroblasts stop laying down scar tissue, and the skin can finally start repairing the damage.
And crucially, the micro-fissures finally close up.
Right.
And when the fissures close, the opportunistic bacteria and yeast are locked back out. The vicious cycle is broken.
That is amazing. And the guidelines detail an induction and maintenance protocol, so you aren't just, slathering it on forever.
No, definitely not.
Usually it's applied daily for a month, then every other day for a month, then twice a week, tapering down to a low-frequency maintenance dose just to keep the inflammation at bay.
That's the standard protocol, yeah.
But the steroids are doing the heavy lifting chemically. The patient leaflets outline practical lifestyle changes to physically protect the barrier, too.
It is all about reducing friction and irritants. The guidelines strongly advise against using soap or bubble baths.
Because soap strips away the skin's natural lipid barrier.
Right, which an LS patient desperately needs to retain moisture. Instead, they recommend emollient washes.
And using barrier creams like yellow soft paraffin or Vaseline.
Vaseline is a lifesaver here.
Because the Vaseline literally acts as artificial armor. I mean, if your skin's natural barrier is broken, pasting a layer of petroleum jelly over it physically blocks urine and friction from entering those microfissures.
Exactly.
It shuts down the Kubner phenomenon mechanically while the steroids work chemically.
It provides a frictionless surface and keeps the moisture out. It is a simple mechanical intervention that profoundly disrupts the disease's ability to worsen through daily trauma.
Let's pull all this together. We started with an immune system gone rogue, where T cells attack the ECM1 cement in the deep layers of the skin. That internal destruction flattens out the REIT ridges, creating fragile, paper-thin skin that easily shears and tears under normal daily friction.
Leading to the cracks.
Right, those tears, the microfissures, they become open doors for yeast and bacteria, triggering a massive secondary infection that feeds right back into the autoimmune destruction.
It's quite the loop.
It is a brilliant, terrible loop, broken only by cellular-level suppression with ultra-potent steroids and artificial armor from emollients.
And if we connect this to the bigger picture drawn from the clinical literature, there's a much darker consequence to allowing this cycle to persist.
What's that?
Well, we've focused heavily on how the microfissures allow microbes in, causing painful, annoying secondary infections. But when the skin is trapped in the state constantly tearing, constantly infected, constantly inflamed, the tissue experiences relentless ischemic stress.
Ischemic stress meaning the blood flow is compromised. So the tissue is literally being starved of oxygen.
Correct. The scarring and constant swelling choke off the tiny blood vessels in the dermis. When cells are starved of oxygen and bombarded by the toxic byproducts of chronic inflammation, they undergo massive oxidative stress.
Wow.
The sources specifically highlight lipid peroxidation happening at a cellular level.
Lipid peroxidation.
Yeah.
So the lipids in the cell walls are basically rusting away.
That is a highly accurate way to visualize it. The free radicals generated by the constant immune response steal electrons from the lipids in the cell membranes,
Which causes a chain reaction.
triggering a chain reaction of damage, much like metal rusting. This constant degradation of the cellular structure, combined with the continuous need for the cells to divide and repair the microfissures, well, it scrambles the DNA.
That sounds dangerous.
It is. It creates a microenvironment highly conducive to malignant transformation.
So the cells are mutating because they are under constant fire and constantly forced to rebuild in a toxic environment.
Exactly. If lichen sclerosus is left untreated or poorly managed, the patient faces a nearly 7% cumulative risk of developing squamous cell carcinoma.
Which is a type of vulvar cancer.
Right. To put that in perspective, in older patients, up to 60% of vulvar squamous cell carcinomas have background lichen sclerosus on the biopsy.
60%. That is huge.
It's a very real risk.
So managing these microscopic fissures, applying the ultrapotent steroids, and diligently using barrier creams. It isn't just about preventing a stubborn yeast infection or making it comfortable to wear jeans again.
No, not at all.
Closing those fissures is quite literally a daily regimen of cancer prevention.
By silencing the inflammation and closing the structural breach, you aren't just saving the skin's architecture, you are protecting the integrity of the cellular DNA itself from that rusting process.
That is incredibly powerful. Next time you hear someone dismiss a dermatological issue as just a simple skin condition, remember the architecture, the vicious cycles, and the invisible battles happening right there in the basement membrane.
It's so much more than skin deep.
It really is. Thank you for joining us on this deep dive into lichen sclerosus. We encourage you to keep questioning assumptions, keep looking deeper, and we will catch you on the next one.